Good morning. Thank you, Mark, and thank you, the organizer, to give me the opportunity to share some thoughts on the application next-generation sequencing, or now-generation sequencing, I would say, newly diagnosed AML. So this is must-do slides. Since I'm the first talker, I just want to remind ourselves how bad we're doing with the AML. It's mostly our SEERS data. In 2017, we expect about 21,000 cases of AML and about 10,000 disease-related deaths in the United States. SEERS quote a 5-year survival of 26.9%. I think probably in specialized centers we can do better than this, but not much better than this. In fact, probably still we can cure only 40% over the younger patients, less than 60 years old, and maybe only 10% older patients, and this is, I think, is a quite generous rate, actually. And definitely with allogeneic stem cell transplantation, we may improve the cure rate, but this comes at cost of toxicity and several other problems. So what's the hope? The hope is in the genetics, in understanding the genetic of the disease. In fact, AML comprises several distinct genetic entities, and the genetic heterogeneity of AML, intended as both cytogenetic and molecular heterogeneity, has been used, is of a clinical usefulness, and is being used for disease classification, treatment guidance, and prognostication. So the diagnostic workup of AML is getting more and more complex in the sense that in the past, morphology, cytogenetic, immunophenotyping is pretty much what you need today. Of course, we incorporate molecular characterization because this is important, relevant for risk-adapted treatment and precision medicine. And particularly, I think virtually all centers now have the ability to gain next-generation sequencing data that will increase our ability to molecularly classify the disease for individual patients. So what's next-generation sequencing is? Well, this refers to usually non-Sanger-based high-throughput sequencing, mostly at least for what is applied to ML is DNA and RNA. There are different platforms of NGS, and most the diagnostic workup actually focus on some subset of genes, those that are more frequently mutated or aberrantly expressed in AML and myeloid neoplasm. An important consideration for NGS is the turnaround time. Of course, this includes several components of the assay, the sequencing, the bioinformatic analysis, and of course, the data interpretation. Usually, a clinician will get back the result in 1 or 2 weeks. What is the utility of NGS in AML? Well, I will say that clearly it's useful for a classification, a pathological report with regard to the type of AML, as done according to the WHO classification, the revised WHO classification. Also, it's important for prognostication. Molecular markers has been incorporated in different classifications that include also risk, prognostic risk, and this is, I would say that the leading one is the ELN, the European Leukemia Network classification. And of course, it's important to decide whether patients can be cured with chemotherapy or allo, risk-adapted treatment, precision medicine approach, according to which mutations or perhaps aberrantly expressed pathways is present in selection of the treatment. Also, it's important for treatment guidance. And this is, we will talk a little bit about how to interpret for, the NGS, apply to post-diagnostic samples, and how you may use to differentiate truly minimal residual disease from the CHIP, the clonal hematopoietic of not significance, basically. And indeterminate potential should be. And of course, the other thing that is important to understand how is the evolution of the disease through the pressure that the treatment apply, so changing the clonal composition of the disease, especially a relapse, which dictate perhaps a change of treatment or a therapeutic approach anyway. So this is a slide that remind us two things. First one, the cytogenetics is where we start in applying the genetic information to the treatment AML. But most important, equally important, I will say that David Greenwade, unfortunately is not with us anymore, but was an extraordinary clinical investigator, was one of the first one, if not the first one, to show us on a large base how the cytogenetic is applied for risk-adapted therapy in AML. But the incorporation really of cytogenetic, the molecular analysis of AML into the cytogenetic, different cytogenetic group really has come in 2013 with this seminal paper by TCGA, particularly Tim Lay was the leading author. For the first time, there was a large cohort of patients that was sequencing using next generation sequencing assays. And there was several, this really is a phenomenal paper. There was several important concepts that came out from this paper. One of the most important concepts that the frequent mutations, when I say frequent, probably about present in 4 or 5% of the patients that are usually discovered in AML, present in AML patients are relatively small, maybe only about 20, 25. And this is something that is very different for solid tumors.